Yeah. Yes. And like so
Good morning, everyone. Hope everyone is awake. Sorry for the early start here today. I'm Malek, one of the faculty at Upstate in the division of endocrinology. Today we're talking about GLP-1, GIP agonists, GLP-1 and 2 inhibitors, masses of many traits, but not one size fits all in diabetes care and beyond. Just some conflicts of interest that I disclose. I don't get any money from any companies, but I am a self-investigator of one of the L2 studies that involve the subject of this talk, namely funding a study on the use of tirzepatide in T1D. Where I'm also involved with the sugar and salt study that investigates the use of an SGLT2 and 1 inhibitor in T1D. This is funded by nonprofits and government organizations, but the medication itself is provided free of charge by the manufacturer last year. Why am I talking about SGLT2 inhibitors and GLP-1 agonists? The use, as you all know, has expanded quite a bit over the last years. With more and more indications, more uses, more benefits have been uncovered. If you look at the most recent guidelines by the American Diabetes Association for 2025, with each successive new guideline, there's a more prominent role of this class of medications. If you look here, sorry. In the past, we used to have metformin being the first-line agent for essentially all patients. But as we see, it's being pushed aside more and more for more and more patients, specifically patients with CKD, heart failure, or high risk for CVD or cardiovascular disease. GLP-1 agonists and SGLT2 inhibitors are becoming more and more first-line agent that should be initiated either as a first-line agent or soon after initiation of metformin. So this is just a rough outline of my start talk. I'm going to talk a little about GLP-1 and GLP-1 GIP agonists of diabetes, SGLT2 inhibitors in diabetes, and then I'm going to expand a little on other indications and other potential uses for these medications. I'm going to talk a little about risk assessment and future directions of ongoing research, including research that's being done here at Upstate. So first, GLP-1 agonists and combined GLP-1 GIP agonists in the use of treatment of diabetes. The discovery of GLP-1 agonists dates back to the mid-80s, where people noticed that if you give a human or mouse glucose either by oral route or by the IV route, you see a big difference in insulin secretion as represented by the C-peptide, where if you give a glucose load by an oral route, there's a much more pronounced secretion of insulin as opposed to when you give the same load of glucose via the IV route. And that difference has been termed at that time the incretin effect, which is been hypothesized to be due to some factor that goes from the gut to the pancreas. And there's was a lot of research about what that factor may be. And one of the pioneers of that research has been Dr. Josh Holz, our very own, who is here at Upstate, has been for many years and has been doing very productive research, who published on the role of GLP-1 since the mid-90s. So we really have a prominent role in this by that process. So as you know, GLP-1 receptors or GLP-1 is secreted by the gut when you have an oral load of food, and that these hormones GLP-1 and GIP affect some effects in the pancreas, where it sensitizes the nerve cell to secrete insulin more robustly in response to a rise in glucose. So it promotes a more robust insulin secretion in response to glucose, to rise in glucose, although that secretion is still dependent on glucose rise. So it's not an indiscriminate stimulation of beta cell insulin secretion. Thereby, you have a lower risk for hypoglycemia with the incretin effect. It also reduces the effect on glucagon in the hepatic circulation. It at the same time reduces gastric emptying, slows gastric emptying, and promotes satiety via direct effects on the brain. And as you see, as you all know, it proved to be a very effective treatment for type 2 diabetes, where the reduction in A1C was quite remarkable, even with the earlier iterations of that pharmaceutical class, namely Exendin and liraglutide, that ran under the name Byetta and Victoza. And as you see with the newer agents, semaglutide, the weekly injections, and liraglutide, you have a more prominent effect that is more pronounced in terms of lowering A1C. And the newest kid on the block is tirzepatide, who has an even more pronounced A1C reducing effect of up to 2.1, which is quite prominent and really remarkable compared to other pharmaceuticals. Just a brief talk about mention of SGLT2 inhibitors and combined SGLT 1 and 2 inhibitors, which is the newer approach for type 2 diabetes. I'll refer to them as just SGLT2 inhibitors for now. As you know, their effect is mainly pronounced affected by the kidney, based on glucose lowering side, where in the normal kidney, you have filtration of filtrate in the glomerulus, and you have a reabsorption of glucose in the descending tubules via SGLT2, which really affects the most of the glucose reabsorption from the nephron, and a small effect also in SGLT1. So smart people have come up with the idea that it would be a good treatment for diabetes by inhibiting these SGLT2 transporters, and later on, the newest approach is to produce combined SGLT2 and SGLT1 inhibitors. And with that, you have more glucoseresis because there is no reabsorption of the glucose, and you'll have more loss of glucose in the kidney, and thereby reducing the blood sugar level very effectively. As you see here, SGLT2s are, and for that matter, SGLT1s are combined glucose and sodium transporters. And what that means is that not only do you get glucoseresis, but you also get diuresis or natriuresis, which would have a diuretic effect that we'll get to later on in a moment. And as you see here, it is also quite effective in lowering glucose levels. The A1C lowering effect is not as pronounced as the GLP-1 and GLP-1 GLP agonists, but still quite remarkable and can be done very safely. Again, the other advantage of this medication class is due to its mechanism of action. There is a very low risk for hypoglycemia, just like with GLP-1 agonists and GLP-1 GIP agonists, due to the absence of the uncontrolled stimulation of insulin secretion. And how about weight control for these two classes of medications? As you see here, and I'm sure you've heard by now, that GLP-1 agonists have a very strong weight reducing effect. This is just an overview of various studies that were done over the years in various agents. And as you see, with newer generation agents, you have a more pronounced weight losing effect of up to 20% for tirzepatide. Very prominent also for semaglutide, which under the name Ozempic, liraglutide, which is the older daily Victoza injection that is powerful, likely due to its pharmacokinetics, just being effective for about 12 hours and then the effect tapering off, versus the weekly injections that have 24/7 action, thereby very prominently reducing the weight. And the main mechanism for that seems to be reducing appetite, delaying gastric emptying, promote satiety due to these effects. And people taking less calories in, again, reinforcing the notion that weight gain and weight loss is really very strongly dependent on calorie intake. The weight loss in SGLT2 inhibitors, canagliflozin, dapagliflozin, and empagliflozin is also there, but nowhere near the effect that you get with GLP-1, GLP agonists. The effect is just much less pronounced. The main effect for that weight loss is likely the gluconeogenesis. You essentially lose calories that you ate in the urine and don't process them into fat. How about atherosclerotic heart disease, heart failure? Early on, there was a notion in these studies that were done to investigate the anti-diabetic effects of these medications, that there's a strong protective effect in terms of cardiovascular outcomes. Now, this is just an overview of some of the studies, and these are composite cardiac outcomes that show that all three mainly SGLT2 inhibitors that are main used have a strong protective effect on cardiovascular outcomes. Empagliflozin, canagliflozin, and dapagliflozin. And that was more pronounced in people with heart failure. The main effect seems to be the diuretic effect, although there's other effects that I'll go to in a moment that may be at play here. This is a meta-analysis of the inhibition of heart failure and impact on CV death and hospitalization related to SGLT2 inhibitors. And also what you see here is an analysis that differentiated people with diabetes and without diabetes in studies that were designed as with heart failure as an outcome. And what you see here, that the effect, the protective effect of SGLT2 inhibitors in heart failure is really not only limited to people who live with diabetes, but also applies to people without diabetes. So this is very strong indication that what might be going on is related to dietary effect. And what you see here, compared to the overall CV event rate, we see a more pronounced effect of SGLT2 inhibitors on heart failure outcomes. Again, re-emphasizing that part of the effect of SGLT2 inhibitors is likely due to the diuretic effect, although there may be other roles at play. And this is just an overview of comparing the SGLT2, showing the effect of the GLP-1 agonists on cardiac outcomes. There's also a beneficial effect here on overall CV outcomes, although the effect is not as pronounced as the SGLT2 inhibitors, and seems to be more related to people with obesity and cardiovascular outcomes overall, as opposed to heart failure. This is, again, another study that looked at tirzepatide, which seemed to have a more protective effect on cardiac outcomes compared to other GLP-1 agonists with their with its combined GLP-1 GIP agonistic effect. So comparing the tirzepatide to other GLP-1 agonists, the effect is quite a bit more pronounced. And if you compare them head to head, this is meta-analysis that was published last year in Nature Cardiovascular Research that did make sensitive analysis of the available clinical randomized trials, looking at the difference in effect of GLP-1 agonists and SGLT2 inhibitors. What you see is the effect on MACE, expanded MACE, all-cause mortality is relatively similar if you compare SGLT2 inhibitors versus GLP-1 agonists. Acute stroke, it's essentially also a wash. Acute MI, where SGLT2 inhibitors really shine is in the setting of heart failure. So that's why the recommendation is usually when people with type 1 diabetes or with type 2 diabetes also have heart failure, the preferred agent is SGLT2 inhibitors. If you have cardiovascular disease that's more atherosclerotic, there is essentially neutral recommendation of either SGLT1 agonist or SGLT2 inhibitor. How about renal outcomes? Early on, it was revealed that, or was found that SGLT2 inhibitors have a beneficial effect in renal outcomes. This was obviously a very strong concern given its effect on renal physiology, that SGLT2 inhibitors were thought to be potentially detrimental to real outcomes. But as this has been looked at extensively, we early on found that there's a strong beneficial effect by SGLT2 inhibitors on renal outcomes. And this applies to people with diabetes. Sorry, here. This is a meta-analysis, as well as people without diabetes. Again, emphasizing the notion that the beneficial effect of SGLT2 inhibitors, just as is the case with heart failure, is also present in people without diabetes for renal outcomes. And for that reason, there's some indication for prescribing SGLT2 inhibitors for people without diabetes for renal indication, as well as for chronic heart failure indication. So this is for acute kidney injury that is de novo, as well as progression of renal failure. Again, this is for progression of renal disease. GLP-1 agonists in the prevention of kidney disease is also, there's some beneficial effect, but the beneficial effect of GLP-1 agonists in renal outcomes is not as pronounced as SGLT2 inhibitors. And it seems to be mainly related to reduction of obesity and overweight with the hypertension that comes with it. And this is outcome trial for the FLOW trial, the more recent trial that we have available for semaglutide. In renal disease, there's a small beneficial effect, and that seems to be flowing through the reduction of weight. The newest event to this progression of use of these GLP-1 agonists and GLP-1 GIP agonists is a more recent trial, the SURMOUNT-OSA trial, that looked at the effect of tirzepatide, the combined GLP-1 GIP agonists, on obstructive sleep apnea. That is weight related. So these are overweight people with sleep apnea, as documented in the studies that were done before initiation of the study. There's two parallel trials. One is trial one, where people were not able to use positive pressure CPAP or a BiPAP at night, and were treated, and we saw a dramatic reduction in outcomes of both in apnea severity and apnea.
Sorry.
Oh,
Sorry.
no worries.
It like got out. It like came out. So sorry.
No. So what you see is cardiovascular outcomes, for instance. There's not much improvement of cardiovascular outcomes unless you achieve a weight reduction of over 10%. So a small trend to reduction of cardiac outcomes, but but the effect is really only present when you have more 10% weight reduction. Again, showing that weight reduction does have a positive effect on cardiovascular outcomes, and therefore it is very likely that a good portion of the effect that we see with GLP-1 agonists on cardiovascular outcomes is related to weight loss. And though it doesn't seem to be completely the only effect, if you look at, for instance, GLP-1 receptor agonist in CV outcomes, this is a meta-analysis that was done in 2024, you see that the effect is there whether you have a BMI below 30 or over 30, again, indicating that there is likely other effects at play here, although 30 is still a relatively high cutoff. So it's likely that there's a strong portion of the weight reduction being responsible for some of the cardiovascular benefits of GLP-1 agonists. But if you look at the targets for GLP-1 agonists, GLP-1 receptors are expressed widely in the body, not only in the beta cells and the gut and in the brain, but also in vessels and in the heart. So there's a strong indication that not only is weight loss responsible for a good portion of the beneficial effects, but there is likely also direct effects of stimulating GLP-1 receptors at the level of the heart, the vessels, the kidney, and at fat tissue, beyond just the effect that you get with weight loss. How about SGLT2 inhibitors? So SGLT2 inhibitors obviously have the main effect on the kidney with diuresis and glucoresis, thereby reducing plasma volume. There's also direct lowering of the sympathetic nervous system activity, but it seems to also be related mainly to the effect on the kidney. The kidney has some role in the regulation of the sympathetic nervous system, and the changes induced by SGLT2 inhibitors at the level of the kidney seem to be directly also reducing the sympathetic nervous activity, but reduction in plasma volume seems to be also a very strong contributor to the beneficial effects of SGLT2 inhibitors beyond glucose lowering effects. And the glucose lowering effect is likely also partially responsive. With the effects of the blood glucose lowering, there's also a higher risk for lowering the insulin level, which in and of itself may have beneficial effects to a point, because when you lower glucose, there's less stimulation of beta cell to secrete more insulin, and that by itself has beneficial effects to a point. But when you reduce the insulin levels to beyond a certain point, there is also a possibility for a higher risk for ketoacidosis, which I'll get to in a moment. Side effects and challenges and mitigation strategies. Just looking at the main ones, UTIs for SGLT2 inhibitors. Usually, we're all warned people to hydrate very well, also to avoid dehydration, and that by itself will hopefully mitigate to some extent UTIs. It is more prominent in women compared to men. We also recommend that people, if they have symptoms of UTIs, get treated right away, potentially discontinue while you're treating the UTI. Mycotic infections, including Fournier's really is a risk that is associated with SGLT2 inhibitors. Usually, we recommend people make sure to clean wet, devices for mycotic infection in the genital area to treat them right away, potentially discontinue the SGLT2 inhibitors for a while you're treating that. Volume depletion, we recommend hydration. Some people need adjustment of diuresis, especially with people with heart failure who are on diuretics. DKA is a big risk with SGLT2 inhibitors. We'll get to this in a moment with more detail. GI side effects are, as we all know, side effects of GLP-1 agonists, mainly nausea, and to some extent also vomiting if that becomes severe. We usually recommend small meals, less fatty meals. That usually mitigates the problem and also gets better over time. That's why we also escalate the dose gradually of GLP-1 agonists with a lower dose and then gradually escalating over a few months. Injection obviously is a problem too. Injection site complications, although that's extremely rare. Risk of pancreatitis is something that we have been debating against. Usually what we recommend is with a history of pancreatitis, we usually are cautious. Usually prescribing it to people with history of pancreatitis, we are usually very reluctant to do that, depending on what the cause of the initial pancreatitis was. People with gallstone disease, especially people who have cholecystitis in the past, there's thought to be a relationship between cholecystitis and cholelithiasis and risk for pancreatitis, although that has never been proven 100%. Risk of medullary C-cell thyroid carcinoma, this is black box warning. Usually it's for most people irrelevant. C-cell carcinoma and medullary thyroid cancer runs in families, usually NEM or medullary thyroid cancer. If someone has that family history, it's important to get a good family history just to make sure. If someone has that history, it is not recommended to use this class of medications, although that's usually rare. And just to be clear, most studies, with exception of one study, there is no relationship between GLP-1, GIP agonists, and papillary thyroid cancer or follicular thyroid cancer, although there was one study that may suggest otherwise, although that is not widely accepted. Perioperative use, we will take a look in a little more detail, obviously with acting, there's a concern for aspiration. I'll go to that a little deeper in a moment. Reduced muscle mass with severe weight loss. So one thing that came up recently is that people who lose a lot of weight not only lose fat weight, but also lose muscle mass. And we should recommend making sure to exercise the muscle, especially in lower extremities. One extreme case I saw recently, woman was not unable to walk due to lower extremity weakness. So it is something that we really have to make sure to mitigate. So SGO2 T2 inhibitor related DKA. So the main effect, although this may not be the only effect, seems to be that due to the loss of glucose to the urine and lowering glucose levels without stimulation of insulin secretion, lowers the drive at beta cell level to secrete insulin. And if someone has advanced type 2 diabetes, for instance, or unrecognized type 1 diabetes, which is a thing, they may lose the drive to secrete insulin to a point where they become insulinopenic. And that seems to be the main driver for high production of free fatty acids, amino acids, but more importantly, ketone bodies, which may precipitate DKA. And this DKA can be quite severe. The half-life of these medications, the effect half-life of these medications, not just the serum half-life, seems to be up to 72 hours. So once you have someone with normal glycemic DKA, they often need to be in the drip for up to 72 hours. And invariably, many times we stop the drip too early, and people go on the floor and recur in DKA. So usually, I recommend making sure to really get solidly out of the DKA before starting the insulin drip of these people. There may be other direct effects of SGLT2 inhibitors at play, although there's no conclusive proof for that. So the main driver seems to be truly insulinopenia that's induced by the glucosuria and the reduced drive of beta cells to secrete insulin in the setting of SGLT2 inhibitors. And what flows from that is the rate of non-glycemic DKA in people with SGLT2 inhibitors seems to be lower in people who are on exogenous insulin. That is at the same time, if at least so many people are on active insulin, for instance, and concomitantly on SGLT inhibitors, their risk for DKA seems to be reduced compared to people who are only on oral medications. So the main mitigation strategies that are recommended in general is avoid using people with an A1C greater than 10. Some people recommend 9. Ask patient to discontinue in case of dehydration and also fasting, which means that can precipitate DKA. It's not recommended for persons with a history of DKA and not approved in people with type 1 diabetes. I personally have a very low threshold for checking C-peptide levels in people to see where they stand in terms of their trajectory of either type 2 diabetes progression or maybe unrecognized monogenic diabetes or type 1 diabetes. And I usually avoid using that class of agents in people with low C-peptide levels. Also, a mitigation strategy that I employ oftentimes is having people monitor their urine ketones once a week and stop the medication if there's moderate or higher ketones. Although this is my personal preference, not generally recommended, but so far not more none of my patients at open hospital with normal glycemic control. What is also coming on the horizon is finger stick ketone monitors that I just used, similar to how glucose monitors are used. So these may become more widely available soon and can be used for as a mitigation strategy. The rate of decay is about 1 to 1,000, odds ratio 1 to 5, 1 to 1.5. Sorry, odds ratio 1.5. Pancreatitis. So early on for the FDA monitored for pancreatitis because this came up in phase 3 trials initially when earlier generation GLP-1 agonists and DPP-4 inhibitors were investigated. The observation that was published in 2010 showed no true relationship with sitagliptin and exendin, which are the older generation DPP-4 and GLP-1 agonists. However, a more recent analysis showed that the risk for pancreatitis is real in GLP-1 agonists and GLP-1 GIP agonists really needs to be mitigated. And what we recommend to people, if there's any symptoms of that may hint at early pancreatitis, to stop the medication that you out early on, and also try to be cautious of anyone who has history of gallstones or specifically also cholecystitis. The risk seems to be reduced in someone who underwent cholecystectomy, although it has not been proven 100%. Also, in people with a history of pancreatitis, if there's clear precipitating event that precipitated that pancreatitis, I'm still very cautious, but it is permitted to get to an agonist, although one has to be very cautious of that. I have a very high threshold for doing that personally. And what about perioperative management of GLP-1 agonists? As mentioned, anesthesiologists are reluctant to initiate anesthesia, general anesthesia in people who are on GLP-1 agonists if they have active drug in them. What they recommended as of April 2024 was relatively simple. Consider discontinuation a week before, so that there's no active drug at the time of general anesthesia. This was in April 2024, and as of November 2024, things got a little more complicated with that, which I think is reasonable. But there's a long recommendation now that was a consensus statement, recommendation by the American Society for Gastroenterologists and also the American Society for Anesthesiologists that had just published an earlier statement in 2024, in 2024. Now there is a more complicated risk stratification and management strategy depending on what risk level is. So it's not a one size fits all anymore, which I think is reasonable, but I won't go through all the details, but essentially you're stratifying your risk depending on what the history is, and get the presence of gastric disease, action time of the drug. There's some concern about was raised in some studies about the progression GLP-1 agonists. And this mainly came out from a meta-analysis that was done and published in 2023, where people who were initiated on GLP-1 agonists have shown a slightly higher risk of early stage retinopathy that occurred early on in the treatment with GLP-1 agonists. And as a consequence of that, for instance, the VA, when you try to prescribe GLP-1 agonists, you have to make sure that they get a retinal exam within 3 months prior to initiation of GLP-1 agonists. So this brought a little of a deja vu because there's also another study that showed almost the same thing with a slightly increased higher odds ratio for new retinopathy. for progression of retinopathy in early stages of initiation GLP-1 agonist, after initiation GLP-1 agonist. This part a little of a deja vu from an earlier study, DCCT, that was published back 2023, 2013. DCCT is the landmark trial that defined how we treat type 1 diabetes. Prior to 1992, roughly, the goals for treating type 1 diabetes were much less stringent than what we have now. So this study enrolled people with type 1 diabetes that were either randomized to aggressive control arm or less aggressive control arm. And what you saw in the primary intervention control cohort that had no retinopathy, there was progressive reduction in retinopathy risk. However, the secondary intervention control that had pre-existing retinopathy, you saw early on, due to the intensification of treatment and lowering of A1C, a increased rate for retinopathy complications that lasted about 2 years, but then flattened off in the long term, was a beneficial effect. So what we think is that going on there is that as you have poor glycemic control, there's early retinopathy that was developing over the years. When you intensify the glucose control and aggressively lower the A1C, there seems to be a increased risk for retinopathy complications early on, although long term still there's a strong beneficial effect. And that seems to be likely the same effect that we see with GLP-1 receptor agonists, mainly increases the risk for early retinopathy complications early on in the treatment course due to pre-existing retinopathy that progresses. The main effect seems to be there. There's complicated effects in the of this aggressive lowering in the retina, mainly has to do with VEGF secretion when you lower the glucose aggressively early on, but it still should not impede treating these people aggressively, but they should be followed very closely by ophthalmologists to ensure that any retinopathy that exists is appropriately treated. How about therapy duration? That is a complicated subject. So here you have, for instance, the results in terms of weight effect in people who were treated with GLP-1 agonists for about 68 weeks, but then stopped. You'll see a strong rebound of weight. And that carries across all the percentiles of weight loss if you analyze percentile weight loss. So what you see here is that the weight loss that you achieve with GLP-1 agonists is very reversible. So that is a little of a concern and a conundrum that we don't have a good solution for. A new trial is a step 4 trial, tried the same thing and divided people into two arms, either continuing the GLP-1 agonist or switch to placebo. And what you see is that the weight losing effect is again reversible as soon as you stop the GLP-1 agonist. What that implies is if you do consider stopping the GLP-1 agonist after a while for various reasons, you should really consult with people and making sure to maintain a very healthy lifestyle and reduce calorie intake and continue lifestyle modification levels that they achieved during the trial with GLP-1 agonists. But it is a conundrum that we don't have a good solution for. At the same token, the glycemic benefits that you get from GLP-1 agonists seem to be also reversible. So this is after withdrawal of semaglutide. This is during semaglutide and after withdrawal, both in people with normal glycemia at baseline. They have a higher rate for prediabetes occurrence, but also for development of diabetes in people with prediabetes. So again, the effect is reversible. So we don't know what the best approach there is, but most people will likely end up staying on these agents long term. So just a discussion of a few new developments. metabolic dysfunction associated with fatty liver disease, and now termed MAFLD, MAFLD. Semaglutide seemed to have a beneficial effect there, where you have a no worsening of renal NASH in people with on semaglutide, a relatively low dose versus placebo. So this was a study that was done specifically for this purpose, and you saw a relatively good effect in preventing progression of NASH. Although another study did not show a significant effect, although there's a relevant trend here on a higher dose of semaglutide. Oddly enough, higher dose had less of an effect, although this was a study that was specifically geared towards examining this question. And it's actually just the same thing in green. And then if you look at dapagliflozin, the dapagliflozin, you also have a similar effect in a smaller study where you have a reduction in liver fat content in males and females on dapagliflozin, whether this translates to resolution or long-term beneficial effect is currently being examined, but there's a strong effect that a strong indication that CRT inhibitors may have a beneficial effects. So people with type 2 diabetes with fatty liver should probably be on GLP-1 agonists and or SGLT inhibitors or both, because many of the effects that we see with these two agents, then having different modes of action, are likely additive, although it's yet to be studied in systematic trials. Substance use disorder. So there's some indication that GLP-1 agonists have beneficial effect in substance use disorder. The theory behind that is twofold. Number one, due to better body weight, lower body weight, better self-esteem, that may be part of the beneficial effect in substance use disorder. This is studied out of Sweden, where they looked at people with opioid use disorder, the rate of hospitalization when they go on or are not on GLP-1 agonists. And what you see is a lower rate for hospitalization for alcohol use disorder in these people. Again, this extreme case with people with established alcohol use disorder, and there's ongoing studies to look at what the effect is long-term on people with alcohol use disorder. Through analysis of currently available studies. Although there's no dedicated study that I know of that examines this in more detail and at large scale. But it may be something that one needs to look at. Some people also hypothesize that one of the effects may be direct effects in the brain by reducing the reward circuit or altering the reward circuit in the brain that is usually stimulated by these drugs that stimulate dopamine and other reward circuit transmitters. As you know, there's many brain targets in the for GLP-1 agonists in the brain. It may be flowing into this reward circuit population that may flow into this. Number one, reduce food intake, but also at the same token, reduce intake of addictive substances. Another new development is the development of small molecule GLP-1 agonists. So all the GLP-1 agonists that we use these days are peptides that need to be injected or ingested at very high doses, such as Rybelsus and the oral semaglutide, to achieve a meaningful effect. The development of small molecules opens the possibility of low dose oral intake of these agents, hopefully at a lower cost, although we'll take a look at this in a moment. It may not be materializing anytime soon. One of the forerunners is orforglipron, which has been developed by Eli Lilly and Chad Wine, a Japanese company that is a little more advanced, now in phase 3 trials. Just another agent called GSBR 1290 by Structure Therapeutics that's currently in development. A third one that was in development by Pfizer has been abandoned due to liver toxicity, as with many other medications as well. There's also a peptide agonist that is currently under development, that is a GLP-1 agonist, dual GLP-1 glucagon agonist, and retatrutide, which is a GLP-1, GIP, and glucagon agonist, not GLP-1, a triple agonist. It may sound somewhat counterintuitive that GLP-1 agonist will be beneficial, but there's some evidence that persistent stimulation with GLP-1, especially at the level of the islet, may stimulate insulin secretion. It may also have beneficial effects on weight. That has to be seen in clinical trials. This is just a press release. There's no peer-reviewed study published yet on orforglipron, but the effect seems to be relatively good, although not as prominent and as strong as, for instance, semaglutide or tirzepatide, but still very, very respectable for an oral agent. Side effects are similar. Again, we're waiting for a peer-reviewed validation for this study findings. So, what about, so given all these beneficial effects on renal outcomes, important outcomes, and weight, so many people think that it may be a good idea to try these medications in people with GLP-1 agonists, with type 1 diabetes. And there's some small studies that have been run and that show that there is benefits, for instance, of empagliflozin on kidney outcomes in people with type 1 diabetes. And as you know, many people with type 1 diabetes do develop renal failure. It's one of the leading causes of renal disease in this country, diabetes in general, but also including people with type 1 diabetes. So what we are participating with in a nationwide study that looks at using SGLT2 inhibitors, specifically an SGLT1/2 inhibitor called empagliflozin in people with type 1 diabetes. And the big reason why usually we don't use SGLT2 inhibitors, as I mentioned earlier, is the risk of DKA, which is a baseline elevated in people with type 1 diabetes. But this study aims to investigate mitigation strategies that hopefully will make it possible to both achieve improve renal outcomes in people with type 1 diabetes safely while mitigating the risk of DKA. And that's usually done by good monitoring of DKA and clear instructions on how to mitigate DKA early in the course of its curves. We are also participating with Eli Lilly sponsored autism trial that looks at the use of tirzepatide in people with type 1 diabetes. People with type 1 diabetes have somewhat disadvantage in terms of weight due to the exogenous administration of insulin, the distribution of insulin in the systemic circulation compared to the sporadic circulation is different from people who have endogenous insulin production. Therefore, people with type 1 diabetes have somewhat of a disadvantage in terms of weight. There's a higher rate for weight gain in these people. So the aim of this study is to mitigate that weight loss, but not only that, also the negative consequences that come from this weight loss. So we're participating in that study that is hopefully starting next month. Also, some ongoing research from the lab in collaboration with Dr. Holz. We looked at the effect of zinc on GLP-1 signaling. As you may know, beta cells have a high concentration of zinc. The islet is a high zinc milieu. Zinc is co-secreted with insulin when insulin is secreted, as there's a high concentration of zinc in insulin-secreting vesicles. And what we found in the lab is there's a strong indication that GLP-1 signaling seems to be strongly inhibited by zinc. And our prevailing theory that we're examining currently in the lab is that endogenous secreted insulin may have an auto-inhibitory effect on GLP-1 signaling, likely to a allosteric inhibition of the receptor itself, or allosteric modulation of the receptor. And we're currently awaiting the review of a NIH grant that proposes to look at this in more detail. I put together a small table just looking at the expansion of the available GLP-1 and SGLT2 inhibitors currently both in development, but also currently available. And one prominent problem that we face when we try to treat our patients with these agents is cost. And as you see here, this list cost for most of these agents, as you see, very high. It's a very high cost. Big thank you for Troy Halso and our pharmacy department who helped me put these costs together. And as you see here, also there is an expanding indication. For instance, sotagliflozin, which is one of the newer kids on the block, is not approved for type 2 diabetes itself, but it is approved in people with type 2 diabetes for the prevention of heart failure and cardiovascular death in patients with CHF and type 2 diabetes and or CKD. And also, for instance, we have empagliflozin is now indicated for CHF and CKD in by itself, just as is dapagliflozin. And so people without diabetes are also using prescribed these medications with an FDA approved indication for CHF and CKD, owing to, as I showed earlier, to the studies that show that the effect on reducing CKD and CHF complications is not limited to people with type 2 diabetes. And there's also a indication for that is now approved for not only for weight management, but also weight-related obstructive sleep apnea for tirzepatide. Tirzepatide, despite the data that I showed earlier with positive effect on MASH, is not yet approved for MASH, but that I think is currently under review by the FDA. Any questions? Problems? Yes.
Thank you for the presentation. So you mentioned about the early retinopathy when you're using the GLP-1 agonist for those who are having diabetes. How about patients who are not diabetes, they're using it for weight loss? Do they still have to go through the retinopathy?
I my knowledge, no. So the question was, with the early retinopathy progression in people who start on GLP-1 agonists, whether this applies to people with overweight. I don't know for sure, but my knowledge, no. Neuropathy usually develops in people with diabetes. So someone with no pre-existing diabetes that's being treated with GLP-1 agonists for weight indication without them having diabetes, I would say likely no. There's no increased risk of retinopathy, but I don't know that this is something that's known for sure. But I would say the risk is probably low for someone without diabetes. Yes.
Great talk. Thank you very much. So given that we used historically creatinine as a marker of GFR, and now we see the use of GLP perhaps decreasing muscle mass and thus decreasing creatinine production.
Yes.
I've seen a number of patients in my stone clinic who are told my kidney function is getting better. And I try to then explain to them that that's probably not accurate when we are using creatinine alone. So I'm checking cystatin C. I don't know if that's something that you guys are commonly doing as well.
We don't, but we should. Very good point. And that complicates interpreting the data on renal outcomes in people on GLP-1 agonists. Again, even further reducing their likely effectiveness. And a very good point. So the point was, sorry for the people who didn't hear on Zoom. And so the question is, in people with if we're treating with GLP-1 agonists reducing muscle mass, that may lead to a reduced creatinine level as creatinine is being secreted by or being filled by the muscle. So with reduced muscle mass, the creatinine level may just get lower because of less muscle mass. And whether we use cystatin C to evaluate kidney function in these people who are losing weight on GLP-1 agonists. And the question is, was whether we use that as a routine marker, and said that no, you should probably.
Use it as sugar.
Sorry, what?
The trial.
Oh, good.
The trial.
And the other.
Nice talk. Thank you so much. So several of my patients, I think a good number, quitted smoking during the GLP-1 treatment. Is there any data about it?
So the question was about smoking cessation by people with GLP-1 agonists, and observation that many people who started GLP-1 agonists and the last decline do find it easier to quit smoking, if I understood you correctly. And that goes to the notion, yes, there's more data on addictive substances, including tobacco, where people find it easier to quit tobacco on GLP-1 agonists, but addictive substances in general, substances of use in general, yes. So that again goes to the notion that there's a possibility of the reward circuit in the brain being altered due to GLP-1 stimulation that may enhance the effect or the ability of these medications to reduce weight, but also to reduce use of addictive substances.
Yeah, like a sleep apnea, they can get FDA approved for the smoking cessation.
Yeah. Maybe we should start a trial. Yes.
Hello, Dr. Muayed. Thank you for the great presentation. In one of your slides, I noticed that do you hear me well?
So we are, that's the trial.
Every time.